I'm going to talk about today what agents we use for urinary tract infections, as well as some antiseptics and antipyretics which we use for people who have urinary tract infections. The first group of drugs that we use for UTI are the sulfonamides. Now, this group of drugs were very much used, especially in previously, because they were the first effective chemotherapeutic agents for the prevention and cure of bacterial infections. Now, they have a wide range of activity against both gram-negative and gram-positive bacteria and are bacteriostatic as well. And they have the spectrum of bacteria that sulfonamides are available for are a lot. You have your Strep pyogenes, Strep pneumoniae, Haemophilus influenza, and etc. However, as you notice in the slides, many strains of E. coli are now resistant. That's why your sulfonamides are not so much used for UTI anymore. So the action of your sulfonamides, they are competitive antagonists of your para-aminobenzoic acid or your PABA. And what it does, it will prevent normal bacterial utilization of your para-aminobenzoic acid for the synthesis of your folic acid. So in essence, it will disrupt your folic acid synthesis in your bacteria. At the same time, it is also a competitive inhibitor of your dihydroperoate synthase. So it will also prevent incorporation of your para-aminobenzoic acid into your dihydropteroic acid. So these agents, your sulfonamides, will act against organisms that need to synthesize their own folic acid. And they are also synergistic with trimethoprim. So it's a potent and selective competitive inhibitor of your dihydrofolate reductase. So usually your sulfonamides, especially your, we call it your cotrimoxazole, where you have your sulfonamide together with your trimethoprim, and this will be discussed later. Your sulfonamides are absorbed rapidly from your GIT, and it's found within 30 minutes in the urine. Peak plasma levels is 2 to 6 hours, and the small intestine is the major site of absorption, and it will readily pass to your placenta. Now, your sulfonamides are classified into 3 groups. There are those agents that are rapidly absorbed and excreted, like your sulfasoxazole and your sulfadiazine, and agents that are absorbed very poorly PO, so they are active in your bowel lumen, such as your sulfasalazine, and there are also agents that are mainly used topically, like your sulfacetamide, your mafenide, and your silver sulfadiazine. Now, there is also the 4th group, which is the long-acting sulfonamide, which is your sulfadoxine. Now, we go to the first group, or those sulfonamides which are rapidly absorbed and eliminated from the body. So we have your sulfasoxazole. Your sulfasoxazole has excellent antibacterial activity. It is also tasteless. So it is used for orally in children. However, you have to warn the parents that it may turn your urine red-orange due to your phenazopyridine. And it can also produce hematuria or crystalluria, and this side effect is seen more in the older sulfonamides. So you should warn the patients that they should ingest an adequate quantity of water, and they are to be used in caution in patients with impaired renal function. Your sulfonamides can also produce hypersensitivity reactions. Now, your sulfamethoxazole, it's both used for UTI and systemically. And this is the sulfonamide which is marketed in fixed dose combinations together with your trimethoprim. Your sulfadiazine, again, what is important or particularly concerning about this drug is that it can produce hematuria or crystalluria, so you should tell the patient to ensure adequate fluid intake, so that the urine output should at least be 1,200 ml in adults per day. So we go to the second group, which are the poorly absorbed sulfonamides. First, you have your sulfasalazine. And it's used for the treatment of mild or moderate ulcerative colitis because it's very poorly absorbed from GIT. That means it will stay in the GIT for a long period of time. And this is also the first drug used for mild cases of regional enteritis and granulomatous colitis. So the effective agent here is your 5-aminosalicylate, and the agent which is responsible for most of toxicity is your sulfapyridine. So what are the toxic reactions? It can produce Heinz body anemia and acute hemolysis in patients with glucose 6-phosphate deficiency. Also granulocytosis. Other side effects are all mild. We also have the sulfonamides for topical use. So these are usually used either for topical or for the skin. For your sulfacetamide, it's for the management of ophthalmic infections. Silver sulfadiazine, I'm sure you've heard of this drug. It's basically what we use for burn patients, since it's used topically to reduce microbial colonization and incidence of infections of wounds from burns. But we do not use it to treat and establish deep infection. So if you've been to burn wards, especially in Vicente Soto, you will see patients using silver sulfadiazine. But you will notice that when you wipe it on patient after debridement, they will be crying because it produces burning, rash, and itching. Your mafenide, it's also used to prevent colonization of burns by a large variety of your gram-negative and gram-positive bacteria. So how do you apply these agents? You apply 1 to 2 times daily with a thickness of 1 to 2 millimeters over your burned skin. But you have to remember to cleanse the wound and remove the debris before each application. And you continue the treatment until you can do skin grafting. And as I mentioned, the adverse effects, you have intense pain at the site of application, allergic reactions, and loss of fluid of evaporation from burned surface. So the last group of sulfonamides are your long-acting sulfonamides, your sulfadoxine. So if you notice, it has a very long half-life of 7 to 9 days, and usually it's combined with your pyrimethamine. And your sulfadoxine is used for the treatment and prophylaxis of malaria, which is caused by mefloquine-resistant strains of your Plasmodium falciparum. And this should only be used for prophylaxis in areas which are at high risk for resistant malaria. And this is because it has severe and sometimes fatal reactions. So regarding your treatment with sulfonamides, with urinary tract infection, it is no longer a treatment of first choice because of the resistance, especially of your E. coli. And the preferred agents nowadays are you can still use cotrimoxazole, quinolones, fosfomycin, and ampicillin, and also your cephalosporins. Now, your sulfadoxazole, it may be used in areas where resistance is not high. And patients with acute pyelonephritis who are at high risk for bacteremia and shock, they are not to be given sulfonamides, but use the other agents. And who are these patients? For example, patients who are immunocompromised and who have really severe symptoms of your urinary tract infection. For nocardiosis, you can give cotrimoxazole and even your sulfadoxazole or sulfadiazine. For toxoplasmosis, the drug of choice here is your pyrimethamine together with your sulfadiazine. Now, if as prophylaxis, it is as efficient as your oral penicillin in preventing your strep infections and recurrences of your rheumatic fever. So for your side effects or your untoward reactions, the most prominent are your disturbances of your urinary tract, as I mentioned earlier, your crystalluria, especially with the older and less soluble sulfonamides. So you should tell the patient to ensure adequate fluid intake, that they must have at least 1,200 ml of urine per day. And the patient can also complain of disorders of the hematopoietic system, like your sensitization phenomenon, agranulocytosis, and aplastic anemia. Hypersensitivity reactions, they can occur especially during the first week of treatment. So it can range from morbilliform scarlatinal, urticarial, petechial, purpuric rashes. It can also present as erythema nodosum, erythema multiforme, and they can also have fever, malaise, and pruritus. Now, other reactions, anorexia, nausea, and vomiting. In newborn infants, it can produce kernicterus, especially if the infant is preterm. And this is because of the displacement of your bilirubin from your plasma albumin. So it is not recommended to be given to newborn infants, especially preterm. And it is not also given to pregnant women near term for the same reason. What are some drug interactions? So you use with caution when you are giving oral anticoagulants or your sulfonylureas and hydantoin anticonvulsants, because concurrent intake of your sulfonamides can potentiate effects of these drugs. So we're going to talk about your cotrimoxazole next, or your trimethoprim sulfamethoxazole. They are combined together because their actions are synergistic, as I mentioned earlier, and it has a wider antibacterial spectrum. However, there are also bacteria which are resistant to this, your Pseudomonas bacteroides and your Enterococci. But if you notice, there are still a lot of agents which are sensitive. Even your E. coli is still sensitive. So for its action, it acts on two steps of the enzyme pathway for the synthesis of your tetrahydrofolic acid. And you have to remember that the concentration is 20:1, meaning 20 of sulfamethoxazole is to 1 of your trimethoprim. So that means your trimethoprim is a more effective agent. It readily enters your cerebrospinal fluid and sputum, and your trimethoprim is absorbed more rapidly than your sulfamethoxazole. Half-life is 10 and 11 hours correspondingly, so that usually it's given twice a day. So uses for UTI, you give it for acute uncomplicated UTI and even for chronic and recurrent UTI. So you give it 4 times a dose, 1 to 2 times per week if the UTI is chronic. So for bacterial respiratory tract infections, it's given for acute exacerbations of your chronic bronchitis, but it's not used to treat your strep pharyngitis because it does not eradicate the organism. It's good for acute otitis media in children and for acute maxillary sinusitis in adults. For GI infections, it's given as a second-line treatment for typhoid fever and as an alternative to fluoroquinolone for shigellosis. It can also be given for carriers of Salmonella typhi and other species, but you have to give it for 2 months. In patients with AIDS, when they have infections by Pneumocystis jirovecii, it's given at high dose 3 to 4 times per day. Your side effects, it can cause folate deficiency manifesting as megaloblastosis, leukopenia, or thrombocytopenia. And it can also produce skin effects like your Stevens-Johnson syndrome or your toxic epidermal necrolysis, but this is rare. For GI, it can cause rare nausea and vomiting or diarrhea. The more common side effect is your glossitis and your stomatitis. CNS, it can cause also some reactions as well as your hematologic. Now, the second group of drugs which are commonly used for urinary tract infections are your quinolones. Your quinolones, they are very easy to remember because usually they have the suffix floxacin. And so you have your fluoroquinolones. These are the ones which we use, and we have a lot. You have the commonly used ones are your ciprofloxacin, your ofloxacin, levofloxacin. These are commonly used PO. Now your sparfloxacin, lomefloxacin, and your plinafloxacin, they can produce phototoxicity and QT prolongation. It's not so much used anymore. Action, it has two actions depending on what type of bacteria. For gram-positive bacteria, it can inhibit topoisomerase 4, but for gram-negative bacteria, it inhibits DNA gyrase. Now, these are also bactericidal against a lot of organisms like your E. coli. For your Pseudomonas aeruginosa, your ciprofloxacin is more effective than your norfloxacin. But you have to remember your quinolones are not active against your methicillin-resistant staph. For your strep, you can also use this. And it can also inhibit your chlamydia, even your mycobacterium, including your Mycobacterium tuberculosis. For anaerobic bacteria, you can use garenoxacin and your gemifloxacin. So it's well absorbed orally. However, for your norfloxacin, it can only achieve low serum levels, so it's only limited to the treatment of your UTI. It's better if you tell the patient to give it 30 minutes before eating because your food may delay time to peak serum concentration. So usually, your quinolones are given twice a day. So your ofloxacin, it's 200 to 400 milligrams. Ciprofloxacin, 250 to 500 milligrams twice a day. The difference here is that your levofloxacin, which is given only once a day. And it has a high volume of distribution, especially in your urine, your kidneys, your lungs, prostate tissue, stool, your bile, macrophages, and your neutrophils. And it's cleared predominantly by the kidneys. So you have to remember if you have patients with impaired kidney function, you have to adjust the dose. Except for your pefloxacin and your moxifloxacin, which is cleared by the liver. So what are the uses of your quinolones? For UTI. For nalidixic acid, only for susceptible organisms. Norfloxacin, only also for UTI. Your fluoroquinolones, they are way more potent than your cotrimoxazole. For prostatitis, you can also use these antibiotics. For STDs, however, your quinolones are contraindicated in pregnancy, but it's active against your gonorrhea, chlamydia, and your Haemophilus ducreae. But it lacks activity against your syphilis. Now, for your chlamydial urethritis or cervicitis, you give it as a 7-day treatment, and it's given as an alternate to 7 days of doxycycline or a single dose of your azithromycin. However, recently, we don't use this anymore because there is very high resistance already. For your PID or your pelvic inflammatory disease, we give this as a 14-day ofloxacin together with your clindamycin or metronidazole. For shigellosis and your salmonella infections, it can also be used. For respiratory tract infections, since it has excellent activity against your strep pneumoniae, your Haemophilus influenza, and typical pathogens. For osteomyelitis, you give fluoroquinolone plus rifampin, but you have to give it as a long-term treatment, around 4 to 6 weeks. Other infections, if you get exposed to anthrax, so you give your ciprofloxacin or levofloxacin. You may also even give this as a treatment of tularemia and as part of your multi-drug regimen for your MDR-TB, especially your moxifloxacin. What are the adverse effects? You have to remember that for quinolones, it's mostly GI. So it produces mild nausea, vomiting, abdominal discomfort. You may have Clostridium difficile colitis, which can result in diarrhea. For CNS, patients may complain of mild headache and dizziness. And rarely they may have hallucinations, delirium, and seizures. And some may complain of rashes and photosensitivity. So you warn them to either wear shades or not go into direct sunlight. It can also cause Achilles tendon rupture and tendinitis, especially in those people who are more than 60 years old, those patients taking steroids, and those receiving solid organ transplants. And it's contraindicated in children and pregnant women due to your arthropathy. So it can damage the tendons and the bones of your children. Your moxifloxacin can cause QT interval prolongation and torsades de pointes. Gatifloxacin can cause hypo or hyperglycemia. That's why it was said, there was an article before that it's not, your quinolones are not to be given to diabetic patients because of this side effect. Now, the next group of, or our next topic will not be, these are not antibacterials, but they are merely urinary antiseptics and analgesics, which you can give together with your antibacterial agents or for patients who have chronic UTI. So the first is your methenamine. Your methenamine can generate formaldehyde, and this is responsible for the antibacterial action. And it's absorbed orally, and however, it's contraindicated in hepatic insufficiency because of your production of your ammonia. And if you give it together with urine acidifiers, like your mandelic acid and hippuric acid, it can increase activity. So it can also produce GI distress if you have very high doses. And the dosage is usually 4 to 8 grams per day. And you give it for more than 3 to 4 weeks. And however, it can cause also painful and frequent micturition, albuminuria, hematuria, and rashes. You don't give it together with sulfonamides because it's mutually antagonistic. So it's not a first-line drug for UTI, but it's more of a treatment for chronic suppressive therapy for people who have chronic UTI, examples would be those who are diabetic or probably those who are on chronic indwelling catheters. They have chronic UTI, so you can use methenamine. The second drug is your nitrofurantoin. Your nitrofurantoin is an agent which forms intermediates which are responsible for damage to your bacterial DNA. So it's also given orally, and you should not alkalinize your urine. However, you have to warn the patient it can turn your urine brown. So the most common side effects, nausea, vomiting, and diarrhea. Hypersensitivity reactions ranging from chills, fever, to as grave as hepatocellular damage. It can also cause neurological disorders like your headache, vertigo, drowsiness, muscle aches, and nystagmus. So the dose, you give it 50 to 100 milligram 4 times a day with meals and at bedtime. But the treatment ideally should not exceed 14 days. If ever you have to extend, repeat courses should be separated by rest periods. And it's not given to pregnant women, children less than 1 month old, and those with a creatinine clearance less than 40 ml per minute. So it's used for treatment of susceptible organisms of your E. coli and enterococci, but if you have patients already with pyelonephritis or prostatitis, it's not recommended. You are better off giving the patient either a quinolone or a cephalosporin. And it's also used for prophylaxis of recurrent UTI. Your phenazopyridine, it's not an antiseptic, but it's just a urinary analgesic. So it can alleviate dysuria frequency, burning, and urgency. However, we don't use this medication that much, or I haven't even tried using this in my practice, because you have to tell the patient that if they have UTI, the symptoms will disappear the next day after they have started treatment, 1 or 2 days after treatment. So, however, there are patients who really cannot tolerate the pain, then you may give this drug. The dose is usually 200 milligram 3 times a day, but again, you have to warn them, it contains an azo dye, so it can color your urine orange or red. Now, your fosfomycin is for prevention and treatment of UTI. It will inhibit your MURA-A, which will catalyze the initial step in bacterial cell wall synthesis. It's marketed as a powder, which is dissolved in water, and it's taken orally. Generally, it's well tolerated with uncommon side effects, which are mild. Fosfomycin can be given to patients who are not able to take all the other medications, probably because they cannot tolerate the GI distress or they are allergic to other medications. So these are the agents. Again, this is just a review of the different agents that I have discussed today. Your sulfonamide, your cotrimoxazole, This in your Goodman and Gilman book. Your quinolones, the different types, and your other agents, your methanamine, nitrofurantoin, and your fosfomycin. I did not discuss it here, but one of the other agents that we also use for treatment of UTI are your cephalosporins, since this has already been discussed in a previous module. So just review on your cephalosporins.